Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good evening, ladies and gentlemen, and welcome to VITALS, a platform for frank and thoughtful discussions around our nation's biggest healthcare issues, as we hear from national leaders who are working to solve these problems through the tools of VITALS: value, innovation, technology, advocacy, leadership, and service. And tonight we're privileged to be able to hear from Dr. Toyin Ajayi. Dr. Ajayi is a family medicine provider who is also the co-founder and chief health officer of CityBlock Health, the first tech-driven provider for communities with complex health and social needs, bringing together communities and neighborhoods for better care. CityBlock's model of care meets individuals where they are, delivering highly personalized primary care, behavioral health care, and social services to its members from communities that are in need and under-resourced. She is certainly qualified for the task. Dr. Ajayi is a graduate of Stanford University, has a master's in philosophy from Cambridge University, and has her medical degree with distinction from King's College School of Medicine in London. She completed a residency at Boston Medical Center and continues to serve as a practicing primary care doctor. Dr. Ajayi, the floor is yours.
Thank you so much. It's such a pleasure to be here with you, and thank you for the warm invitation and the welcome. So as usual, I want to start with a patient story, which grounds me in what we're trying to achieve and why. I have so much to be grateful to my patients over the years for teaching me about what really matters, for grounding us in what our goals should be as we build towards a better future for all. So this woman, I'll call her Mary Beth, has a major psychiatric disorder diagnosis, a number of chronic medical conditions, and she was a new patient in my practice. This is probably going on 15 years ago now, maybe 10 years ago. But the timing of her visit happened to be very shortly after another inpatient admission for a complication that would likely have been avoided through appropriate use of her prescribed medications. And it happened to be a warm spring afternoon in Boston, and which is rare. And so instead of conducting the visit in my office, I decided to take her for a short walk around the neighborhood. We were going to make the best use of our 17 minutes. And we stepped out of that space, my space, where I had power and I knew where everything was, and it was controlled, and out into the sunshine. And we began to talk. And she talked and talked. She told me about all sorts of things, about her childhood, her relationships, her many hospitalizations, all the facets of our health and social systems that she touched, her long stays at inpatient psychiatric units, her experience as a child in the foster care system. She invited me into her life, giving me glimpses of the resiliency, of the insight and the courage that she displayed. And I felt this buoyant feeling of the fresh air on my face as we walked by, and just the deep privilege of being able to hold space and be invited into such deep confidence by a person I'd only just met. A true privilege to us as healthcare workers. I felt so close to her. I shared things about my life. We built a rapport. We sort of shed the traditional patient-doctor roles and began increasingly to relate to each other simply as fellow humans. We kept walking. And finally, as we turned to go back to the clinic, she said to me, "Look, I just want you to understand, Dr. T, I'm not non-compliant. I'm defiant. And I did this like silent version of the like mind blown emoji. I got goosebumps. Her words were so rich with insight and meaning, and they totally, literally stopped me in my track. The language that she used, non-compliant, was so familiar to me. It's such common lexicon in healthcare settings. It's how we talk about patients who have the audacity to not do exactly what we, the esteemed, the all-knowing, all-powerful medical team, tell them to do. And Mary Beth, as a person with multiple chronic conditions, with frequent hospitalizations, with a complex and troubled background, she had heard this term applied to herself many, many times before. She and people like her are often described as frequent flyers in the medical system, as high utilizers, high cost, high need patients. We sort of wrap it up in an affectionate term. Sometimes we call them MVPs to the emergency room, but she knows what that means. And the assumptions underlying this language places patients in the role of a supplicant. They're passive recipients of recommendations, of guidance, of directives with which they must comply. And when they don't, when they end up in pain, when they end up suffering with complications, when they're rehospitalized or disabled, we label them. We call them non-compliant. We imply, and sometimes we even outright tell them that they are to blame for the outcomes that they're experiencing. That's how the traditional healthcare system treats patients like Mary Beth and the folks that I've spent my career serving. So to hear Mary Beth's framing was like a jolt to my system. She stared me down, eyeball to eyeball, Black woman to Black woman. She made sure I understood that for her, being a survivor, being resilient, being alive, being human meant asserting her own agency. It meant sometimes choosing not to do what she was being told by the overbearing, disconnected, judgmental clinicians who swarmed around her like flies. She rejected the healthcare system's assessment of her and spoke her own version of the truth. I'm not non-compliant, I'm defiant. And my first reaction was to feel ashamed. I'm sure I'd used that language before in a history and physical note to describe a patient with chronic alcohol use who showed up yet again in the emergency room with unexplained bruises and his blood pressure out of control. I'd use lots of other words like that to describe patients, the CHFer, the diabetic, the vascular path, and I could see in an instant how damaging and how wrong I'd been. I felt called out, or as we say at CityBlock now, I felt called in, and I needed to sit for a moment with my own culpability for a system that has misunderstood and marginalized the very people we were charged with caring for. Mary Beth's words continue to guide and inspire me as I think about what it takes to build and sustain an experience of care for folks like her that is respectful, that's dignifying, and that's fit for purpose. About 4 years ago, when I began the process of co-founding CityBlock Health, which is a healthcare provider organization focused on delivering the highest quality values and value-based primary care, behavioral health, and social care for communities with complex needs, Mary Beth and so many others like her were at the front of my mind. How could we build a system of care that would make sure that Mary Beth never felt judged, misunderstood, or labeled? How could we show up in a way that respected Mary Beth and all of the choices she made, supported and valued her humanity and her agency no matter the circumstances? How could we ensure that we aligned our goals for Mary Beth with the goals she holds for herself, so that she never felt the need to act out her defiance of the very systems that were supposed to be caring for her? And finally, how could we learn to recognize the many complex and nuanced ways in which trauma shows up in our patients' behaviors? Learn to listen for the why behind the what of behaviors that wouldn't otherwise make sense, not taking medications, continuing to use alcohol. Could we understand that as a form of survival? And so as we built out our teams and tools, 4 core tenets have come to the forefront for me, and I'd love to share them with you. First, language matters. It really, really does. All of us in healthcare have to be mindful of language, both in public and private spaces. How did Mary Beth know that doctors and nurses often refer to patients who don't take their medications as prescribed as non-compliant? How did she feel when she first encountered that label on a discharge summary, overheard it from her hospital bed, perhaps even said directly to her face? When we describe patients as challenging, as non-compliant, non-adherent, or we identify them by their disease states, we strip people of their humanity and establish an implicit opposition between the patient and the care team that undermines the notion of partnership and collaboration. We found at CityBlock that a combination of purposefully empowering staff to call out breaches of our culture of caring and establishing language norms is an effective way to build a vocabulary around care that reflects the values of patient-centeredness and compassion. We don't call the people we serve patients, we call them members. We're trying to flip the hierarchy. We're trying to change the notion that we are doing something to them, and really framing the work that we do as a partnership with the members who choose to be a part of our community. Second, the design of care teams has to be focused on fostering and sustaining longitudinal, trusting relationships, on meeting our members where they are. We've seen a lot in recent years of the move towards team-based care that brings a lot of efficiencies at the practice level, spreads care out amongst the larger numbers of individual, everyone practicing towards the top of their licensure. But we have to be careful to not dilute the dose-dependent power of a meaningful, trusted relationship, connections between a member and a care team individual. We believe that every person we care for deserves to have a person, a named, accessible, trusted member of their care team who they can rely on to be their point person and their entry point into the healthcare system, because it's so often chaotic, disempowering, traumatizing, and uncoordinated. At CityBlock, this person is our community health partner. We hire folks from the communities we serve who don't have clinical backgrounds or licensure necessarily, but who are empathic, resilient, tenacious, culturally fluent, and understand that their role is to show up all the time for the members whom we serve, treat them with dignity, to provide them access to the services that they need within the healthcare system. And we have to be willing to go where they are, both physically and emotionally. Now, I'm not suggesting that every patient needs a care and a home visiting model, or that every primary care doctor should take their patients in walks around the neighborhood. But what happened when I stepped outside with Mary Beth created a space for an honest dialogue as we faced each other on equal footing outside of the charged environment that for her recalled memories of disempowerment and mistrust. And I remember that all the time. I'm so humbled by the idea that when I, as a physician who spent most of my adult life now in healthcare settings, when I set foot in a hospital or a clinic, I feel powerful, I feel comfortable, I'm confident. It is exactly the opposite experience for a patient, someone who's sick and vulnerable. Sit in the waiting room, put on this stiff paper towel thing, wait for me. Don't know what's going to happen next, who's going to walk in the door. Imagine what it feels like to flip that dynamic. For me as a physician, to go into the community, to ring the doorbell, wait for someone to let me in, take my shoes off if that's the custom in their home, wait to be invited, shown where to sit. Be uncomfortable. I feel that sense of uncertainty now. And they are sitting in their favorite chair, the sofa, at the dinner table. I'm their guest. What a power dynamic, and how important is it to meet people really where they are? Similarly, we have to meet people emotionally where they are. If they're not ready, like Mary Beth is not, to take their medications, that's okay. We'll still show up for you. If you're not ready to talk to us, we'll keep coming back respectfully and persistently until we've earned the right to your trust. And we know that healthcare needs happen 24/7, not just in the hours of 8 to 6 or Monday to Friday. And so we show up for people 24/7, virtually, in person, in their homes. We accompany them to community visits just to make sure that they know that we're there for them. The third is that effective teams have to make a point of identifying and prioritizing common goals, goals that the clinical team and the patient agree on. They may not be the most clinically important endpoints, but if they're important to the patient, ultimately, it's important to effective collaboration and engagement. And for clinicians in particular, this is harder than it sounds. It means that sometimes we have to accept that poorly controlled high blood pressure or that preventable hospitalization and focus on what matters to the person we're serving. Maybe it's housing or food or a sense of belonging or an upcoming life event. We have to conquer this common ground first, because if we fail to do so and we forge ahead instead with our agenda without being certain that it aligns with the patient's, then we risk creating opposition. We risk fostering a situation where a patient stops taking their medicines as an act of defiance, as a way to wrest power and control from a clinical team that's driving towards a different goal. At CityBlock, we do this through the development of a shared member action plan, where we describe and prioritize the things that matter to our members, creating a space where we can align on priorities, negotiating sometimes between the things that I, as the doctor, would want and the things that the member we're serving really, really wants to happen. listening to all the voices around the table, the psychiatrist, the community health partner, the member themselves, and ensuring that we're truly aligning on a set of goals that we can all get behind so that we're not creating that opposition that we so often see in the healthcare system. And finally, we in healthcare organizations must recognize that our outsides reflect our insides. Our internal organizational culture, how we treat each other, how we treat our teammates, that shows up in the ways that we treat our members and our patients. We understand this conceptually. This is a well understood principle in organizational behavior and organizational development. Human resources leaders will tell you this. We know this, and yet we don't always act this way. How many of us work in healthcare institutions where our team members are disengaged, where we have not addressed race and racism, where we haven't addressed gender equity and balance, where we say things about people behind their backs, where we create cultures that are competitive and unkind, that are not transparent? All of those core foundational organizational cultures show up in the way that your patients experience care. And as we went back to the work of trying to figure out how to ensure that every single CityBlock member feels seen, feels heard, feels respected and valued, and aligned with their team member, we realized we had to do that work on the inside. And what a journey we've been on. So humbling, especially in this sort of national climate, this conversations we're having about race and equity and justice, to bring that into the work environment, to ask people to bring their whole selves into the workspace, to grapple with the isms and the biases and all of the historical injustices that surround our society, and know that in doing so, we are ensuring that we can show up for the members we're seeking to serve. So powerful and so important. And so as I sort of reflect on Mary Beth, I'm still in touch with her, and I'm totally grateful to her for allowing me to not only really hear her message, but to share it with other people. I think about the lessons that we can pull forward into the work that we do and into the ways that we show up for the patients that we're serving and for the communities we're trying to influence and shape for the better. Thank you so much.
We're now going to introduce Ms. Cheryl Power, the managing editor of the Akron Beacon Journal, who will be the moderator for the question and answer portion of the session.
Hi, thank you very much for having me here today and being able to listen to quite an inspiring message that was shared there too. I think a lot of people hearing a physician putting themselves in the place of a patient is very eye-opening and refreshing and vital, because I think sometimes the patients do feel like unnerved or, you know, in a position of lack of power, and hearing about trying to change that dynamic, I think could be beneficial for both parties, definitely.
Thank you so much.
So how is Mary Beth? You said you're still in touch with her. Is she doing well? And did she finally lose that defiance? Although maybe she doesn't need to all the way, right?
I don't think she needs to. I think that's who she is, and she's doing well. She's tremendous.
That's great. That's great. I do have a question that came out. CityBlock is going to be expanding into Ohio, right?
We are.
Cleveland, Columbus, Cincinnati in the next year. Can you talk a little bit about that? And is there opportunities for NEOMED students maybe to get involved?
Thank you for the question. Yeah, we're very excited to have recently announced through a partnership with Molina that we will be moving to Ohio soon. We as I sort of mentioned, we very much anchor on learning communities as we seek to serve and become part of them. And so a lot of our work in the lead up to 2022 will be meeting folks, learning from you all about what your communities need, and starting to figure out how we can best be supportive of this ecosystem. So through that, certainly opportunities for folks to join our team, and we'll be sort of advertising positions as they become available, as well as for folks to contribute in a whole host of ways, and just helping us understand and humbly seek to be part of the communities that you all know so well.
No, I'm sure no patient is the same, and that's, every patient's unique, but is there some commonalities, some conditions or situations that you find more commonly among the patients that you're trying to help and serve?
Yeah, so we focus very much on caring for people who have complex needs, and what that typically means. So there's sort of the textbook definitions, multiple chronic conditions, a serious mental illness, folks who struggle with substance use disorder. But truly, what I'm increasingly finding is the common thread, as these are people who tend to have been marginalized by our health and social systems. These are folks who have struggled to access primary care, mental health, and social services in the way that they need to, and for whom the traditional healthcare system that requires you to come to the clinic in a certain time, take the meds as they're given to you, navigate the complexities of our health and social system is just not sufficient. And throughout all of that is a real thread of trauma, of social trauma in particular, that seems to predispose, no surprise, to worsening outcomes and to worse outcomes. And so we seek to serve folks who really fall in that intersection where they need more, they need something different from the healthcare system. Often it's driven by mental health and physical health conditions, but it could also be simply a combination of that and social needs. And those are the folks that we tend to serve.
Yeah. No, obviously, like you said, a complex group of individuals, but how do the outcomes then compare that you see with CityBlock to traditional care models as far as chronic disease management?
Yeah, absolutely. So we see that the members we serve are more engaged, significantly more engaged than traditional chronic care model. So we tend to, one of the kind of core foundational first steps in achieving change and outcomes in a population, of course, you got to find people, and you've got to be able to build engaged, trusted relationships with those folks, such they can tell you what's going on with them, so you can start to build solutions to their challenges and their needs. And so we are exceptionally good at finding people and engaging them, and keeping them engaged with our model over the long haul. We also find that we're able to provide clinical care that they have not prior to that had. So they haven't had primary care, mental health, social care. We're able to see their uptake and their engagement with those clinical services increase. And then ultimately, where this shows up in sort of marked impact is in the reduction in hospitalizations that could have been avoided through better community-based care. And so we see acute utilization, emergency room visits, inpatient stays go down after engagement with CityBlock. And we see their total medical spend go down, even as primary care and social services and mental health care goes up, and quality improves as well as engagement. And of course, one of our core measures is satisfaction, and we see very high, we measure our net promoter score, we see very high satisfaction in the population that we serve.
That's great. And going back to your story with Mary Beth, where you really stepped outside your comfort zone. I mean, you did, you stepped outside your office, and it sounds like that's kind of what you're asking the people who participate, the healthcare professionals who are involved with CityBlock, to maybe not do what's in their normal comfort zone, to do something a little bit different. Have there been some barriers that you've had to overcome to get the health professionals who are part of CityBlock on board with this concept?
I wouldn't say barriers. I think we're all learning, right? And so, one of the things we do find is that there's so many healthcare providers who have felt frustrated with the way that their day-to-day life has been so far. They know that feeling. I used to describe sort of the members that we serve as the type of patients who, when I was practicing in a federally qualified health center, if I saw their name on my schedule for the day, my heart would sink a little bit. And it's for one of two reasons. I knew one of two things would be true. Either they wouldn't show up for the appointment, and I'd be left there wondering, are they sleeping on a park bench somewhere? Are they in the hospital with frostbite? Did something terrible happen to them? Like, where are they? And I have no idea, right? I wouldn't know. Or they would show up and it would totally derail my day, because I have 10 minutes to get in and out of my clinic visits, and I knew this person needed more time. And so I had two choices. One is I could ignore all the things that they needed from me, or I could lean in and do what they needed, and I would be late for everybody else. You were sort of caught in this sort of unwinnable position. And so we find a lot of clinicians feel that tension. They want to do right by their patients. They came into this field and because they wanted to serve people. And when we realize is that our systems aren't really set up to care for people in the way that we know would drive outcomes for them and impact for them. And therefore, CityBlock provides a really interesting and exciting opportunity for folks. Where it's been challenging certainly is learning together all of the things we have to unlearn in order to be right and to show up for our members. And there we just listen humbly. We listen to our members, we adjust, we shift, we pivot until we get it right. And certainly I think it will be a journey. This is a system that was many decades in the making. We're all educated in traditional healthcare systems. And so we have to learn how to work together in teams, how to show up for our members, how to shed all of the power and distance that comes with our white coats and our experience, and really let ourselves be seen and be vulnerable so that we can partner with people. It takes time.
I'm wondering too that when you're saying that, I mean, you go into medicine to help people. You want to make people feel better. I mean, writing a prescription, knowing it's good for them, and they're going to throw it away or not being able to fill it, that doesn't help anybody. And it could get you frustrated with all, like you said, the obstacles of limited time and insurance and all the different things. But this model seems to be different to really get to know the patients. Do you think this model is helping in some ways alleviate some of that provider burnout and frustration with the healthcare systems, beneficial to the providers too?
I would love to think so. I mean, I can't say definitively, but there's a school of research that describes a lot of the burnout that providers are experiencing right now as moral injury. And that's a term that came actually after the Vietnam War, where they saw that PTSD amongst soldiers was actually disproportionate to the level of violence that they'd experienced. And researchers and psychologists posited that there's something about fighting and working really hard at something that feels at its core a little bit futile, that is more emotionally damaging than even just the act of doing the work itself. And so there's a school of research that suggests that going to work every day as a clinician in a system where you just don't feel like you can move the needle for the people who really need it is morally injurious to those providers. And so you would believe, or you could believe, that being able to step out of that could start to be a form of healing. Certainly on a one-on-one basis, our clinicians describe that feeling of being sort of liberated to do the work that they really feel passionately about, feeling freed to spend time with people, to get to know them, to manage their schedules in ways that are responsive to the patient's needs and not just to the schedule. But we don't have enough data points yet to sort of conclusively say that. I will say that that we attract some unusually, remarkably kind, compassionate, flexible providers. And that is just such a huge part of the culture of the organization.
Right. So as you've been getting CityBlock started and then building it and expanding it, what are some of the biggest challenges you've faced, and how did you overcome those?
I don't even know where to start. I mean, anyone who started anything will tell you that's really, really hard. Sure. Everything's hard. Beginning to having the audacity and the hubris to have an idea that you think is worthy of the funding and the attention, and convincing people to quit their perfectly good paying jobs and come take a flyer on you. That's hard. It takes a lot of courage and a lot of self-confidence, keeps you up at night for a while. Taking on financial risk, as we do in value-based payment structures, where we say we're so confident that our model of care, even though it's resource intensive, we provide all these incredible clinical services, our teams are very robust. We believe it's going to pay dividends on the back end because patients are going to spend less time in the hospital, but we're going to take that risk up front. That's pretty scary and hard. And then, being a human being in the middle of the COVID pandemic, being a leader in the middle of the COVID pandemic, leading teams, caring for patients and communities. But I think that there's something about recognizing the status quo isn't working that is incredibly emboldening, because doing more of the same will not get us different outcomes. We know that. And so there is something very freeing about the notion that we've got to try something. And to be, in this endeavor now, we launched our first market almost 3 years ago now. So to be 3 years into serving members, CityBlock members in this model of care and see it work is so rewarding and so humbling, and starts to make the hard things up front just a little bit less difficult, because I have conviction that's been borne out in evidence that this different thing we're doing may actually be a better way to serve the people that we desperately want to help and to meet.
Right. Now you mentioned COVID and the COVID-19 and the pandemic, a little obstacle everyone in healthcare is facing, but particularly the very folks you're talking about serving seem to be at high risk. You know, they have complex medical conditions and issues. So how has COVID-19 pandemic affected your patients and that you're trying to serve, and how have you adjusted to that?
Yeah, it's been a really hard time. So I'm currently in New York City. Our largest market is in New York, and so we were the first wave of the impact of the pandemic. And when we started to see the data come out from China and from Europe, we all looked at each other and were like, oh, we're in trouble. You know, our people, to your point, our members have multiple chronic conditions. They largely live in poverty. Our communities of color are overrepresented in the proportion in the folks that we serve, and we knew that that disparities in health outcomes would be, from the get-go, would be a really big problem to solve. But we also knew that we needed to do something about it. And so the first thing that we did was build. Excuse me. Was my apologies. New York City apartment. Didn't see that coming. Was to build a custom algorithm.
We understand, right?
I know, the work from home. Even with the background, we can't keep the home from coming into this. We realized we needed to build an algorithm to help us identify and outreach to our highest risk members first, to ensure that we were getting to them with the type of education and tools that we had, which at the time were somewhat limited. And so we built a model. We actually published it and made it open source for other people to use, that helped us identify people with comorbidities and social needs who were likely to be at high risk. And we called every single one of them, and we kept calling, and we were educating, we were screening for symptoms, deploying care teams to people's homes once we had COVID tests available, actually providing treatment in their homes, counseling folks, really just trying to make sure that most importantly, people did not feel abandoned or alone, even throughout all of the social isolation that we knew was going to ensue with the lockdowns. But our population struggled. We certainly saw, increased hospitalizations amongst a small segment of the population with very significant needs while there was community spread. And we saw, like everyone, we saw people grapple with personal losses in their lives, family members who they lost, friends who they lost, and then the impacts of social isolation have just been profound. We've learned a tremendous amount about how to help people stay engaged and connected digitally. Even folks who are not tech savvy, we got them on technology, guided them through, started moving all of our programming digitally, pivoted a lot of our work to virtual care. And we also deployed a new type of our team member on our care teams. We deployed emergency medical technicians and paramedics to go to people's homes to make sure they had the treatments that they needed, to connect them with our physicians virtually if need be, really just making sure that we showed up for people wherever they needed us to be.
Now, going along with COVID-19 and talked about some defiant patients, what about the anti-vaxxers or people who, for a variety of reasons, don't have trust, don't want to hit the vaccine? How does CityBlock managing that?
Yeah, as we would with anything, right? Like, so first of all is coming, and I do think about like language here too. There's been a lot of stigma, I think, associated with people who for various reasons choose not to take the vaccine or choose to defer it. What we know is that there are lots of really good reasons for people to feel unsure and mistrustful of the vaccine. We understand that. I think honoring that and really meeting people where they are from a stage perspective in terms of their understanding of the vaccine and understanding what matters to them is really important. Showing up non-judgmentally has been critical. And then focusing on education with the goal of helping people make the right choices for them has been really, really critical. We've been doing a lot of the work that you see. We see more broadly. What we know is that trusted messengers are much more likely to help a person make the decision to choose to take the vaccine. And so relying on those relationships of trust between our care team members and the members we serve to help them, inform them, and help them make choices that make the most sense for them. And when you think about how powerful trust is as a kind of core foundation, as a chassis on which to deliver care services, I mean, trust is the belief that the person you're talking with or the system you're interacting with cares about you and is doing things in your best interests. And if you believe that, then we can have a conversation about why I think it's a good idea for you to take the vaccine. That's what's necessary. And when we have all these top-down models and these sometimes quite stigmatizing approaches to directively telling people what they should and shouldn't do, we degrade that trust and we make it more likely that people will want to behave in defiant ways, even if we may have been otherwise able to get them to understand that this is a choice that they want to make.
Right. Now, the model that CityBlock has developed, is it applicable for specialty care? I mean, we're mostly focusing on primary care, but is it applicable to specialty care too?
Yeah, so one of the core tenets of the model that we deploy is value-based care. So the idea that we are incentivized to invest in parts of the care continuum that drive better outcomes overall. And you can only do that through a payment structure that doesn't say we're gonna pay for reactive care, we're gonna pay for hospitalizations, expensive surgeries, sometimes expensive specialty visits at a much higher rate than primary care. And we're only going to allow primary care to occur in these sort of small doses and behavioral health care to occur in these small doses that they typically do. So what we do is we take financial risk for the total spend for an individual in a community at a population of people, which means that we can then reallocate and reinvest those resources in ways that drive better outcomes for that population. And so that means in some instances, we want to be engaging with specialists differently, right? We want to be engaging with specialty providers to help them provide the type of care that's high value to our members. But we also want to understand what those high value services are within the care continuum, because some specialty services may be highly reimbursed, but may actually not deliver significant value to members in terms of meeting their overall care goals and being a useful and valuable investment in resources. And so think of our model as a holistic approach that incorporates specialty care, but that really believes that the key levers to improve outcomes are behavioral health, primary care, and community-based social supports.
Earlier, you were talking a little bit about the trauma and its role in disease and health. And I was wondering if there is an example of a patient who had health problems related to obesity, and how did you develop a care plan, realizing that the obesity could be related to whatever trauma they were dealing with in their life?
Yeah, so it goes, I'll give you an example. And I think just recognizing that trauma plays multiple roles in the way that that folks experience the healthcare system, and also in the way that folks show up in the healthcare system in terms of their prior experience of trauma being a risk factor and a precipitant for worsening health outcomes. But imagine you're a person who's struggling with obesity, and you live in a sort of low income neighborhood that's maybe not super safe at night. You don't have a ton of nutritional literacy, which means that you haven't had the chance to kind of learn about which foods are healthier than others. You're shopping on a budget, you're busy, and you see your healthcare provider and for back pain or for knee pain, and they say, well, your knees hurt because you're overweight, you should lose weight. See you next time. And you come back and no surprise, not much has changed. And the refrain continues to be the same thing. We know from the research that actually that folks who have obesity are often really experience stigmatization in the healthcare system. and often experience their needs being dismissed by healthcare providers because there are so many things that are associated with obesity in theory. So my knee pain, my back pain, my shoulder pain, my what have you. There's this feeling that it all goes back to this. Just lose weight and you'll be fine. Imagine instead if you said to this person, "What are your goals?" And they say, "Well, my goals are to be able to walk up the stairs of my daughter's apartment so I can watch my grandchild while she's at work. My goals are to be able to do the grocery shopping all on my own without having to stop because I'm in pain and get help. My goals are to reduce my need for insulin so that I don't have to spend all this money on the copay for this really expensive medication." Well, let's start there. Let's talk about those goals. And then we start to say, what are the things that are challenges to achieving those goals? Well, I don't have a place to exercise. I don't know what healthy foods to eat on a budget. I get really, really sad and lonely at night. And that's when I just can't stop but going for the French fries or the bag of potato chips. And like, who hasn't had some form of this challenge, right? What we know about the sort of the cognitive burden of poverty in particular, when you layer that on, is that when you're just trying to get through the day and you're balancing a budget and you're worrying about paying the rent, you don't have a lot of willpower, you don't have a lot of creativity, and you certainly don't have a lot of resilience at the end of the day. And so let's put in place some real tactical interventions to help and solutions to help unburden this person. And let's not get obsessed about what the scale says. Let's get obsessed about, can you walk up a few more stairs this time? Were you able to do the grocery shopping? Are you feeling just a little bit better on a day-to-day basis? And hey, if you slip and you eat that bag of chips, like, no one's going to judge you. You didn't disappoint me. We're humans. We fail sometimes. We get back on the horse. There's something about the way that we show up and that coaching and that compassion and that accompaniment that is often missing in the healthcare system. And what you do is you then re-traumatize people because they continue to feel unheard, devalued, disrespected by that constant refrain that they're just not good enough.
I think you talked about, I think you said earlier you worked at a federally qualified health center. That was one of your roles.
Yeah.
So I'm curious, how are the aims and services provided by CityBlock different or similar to those aims and services at the federally qualified health centers?
Yeah, so we grew up with the same sort of values and principles, and this real accountability to communities. And I think what's very different about our approach is that we are equipped to take financial risk, which allows us to change the operating model. And so what I mean by that is that FQHCs have often very similar goals, but they're still beholden to a fee-for-service structure, which means that you don't get to do home visits that often. You don't get, up until recently, paid to do the phone call to the family member to follow up on whether someone got their meds. You may have a social worker, but behavioral health services are typically very poorly reimbursed. And so often the social worker's in the tiny windowless room in the basement somewhere, and the wait is 6 weeks long. These are not a fault of intent or values or goals, but a structural difference. And it was really important to us in the way that we established CityBlock, that we had the mandate, the resources, and the tools to be financially at risk for these populations, which means that we can make investments in the model and the approach. We can build technology that's fit for purpose. We can build data tools and insights and decision support for our teams. We can do things that many providers and FQHCs wish they could, which is like put everybody on the same in the same chart so we can all see what we're doing. The doctors, the social workers, the community health workers, the psychiatrists, everybody on the same page. We can huddle, we can case conference, we can really, really get into figuring out what people need. The structure, I think, allows us to be positioned to scale the model that we have that we've built in a way that I think a lot of traditional fee-for-service providers have struggled to do so.
And while we're comparing and contrasting systems, somebody else asked a question looking at accountable care organizations. That is your organization, is CityBlock similar to an ACO? And if so, how is it similar, or how is it different from the ACO model?
Yeah, as we know, I'm sure the person asking the question is well aware, ACOs come in many different flavors. And so I'll pick on the sort of community-based provider ACO structure, which again, to sort of reiterate my prior point, tends to be an infrastructure overlaid around a fee-for-service chassis. So by that, I mean, you have practices that are providing fee-for-service care, and they take some accountability, often not as much risk as we do economically, and are able to provide some wraparound services around that. But typically what you're doing is some change management and transformation from within the existing system that continues to do traditional fee-for-service care in addition and alongside the ACO model. And I think what has been so rewarding for me has been the opportunity to build from the ground up an entire system where all we do is value-based care, focused on these populations with complex needs. Everything that we do is that. So our technology, our tools, our systems, our teams, our training, our infrastructure, everything is baked around the idea that we will meet our members wherever they are, do whatever we need to do to build trusted relationships with them so that we earn the right to help them stay out of the hospital. Really, truly. And that's a very different framework, I think, from a lot of organizations that have layered on value relationships on top of their existing systems.
Now, obviously, you've been a leader in this, stepped out and decided to try to create a new model here. And a couple of people wanted to see if you could talk particularly to address the medical students and the pharmacy students who are on this call. Like, how do you develop that, leadership to be able to, what can you do starting when you're a student to be able to develop those leadership skills to become a leader in the industry?
Yeah, I think a few things. I think the first is you got to listen. Listen to, I think one of the most important, factors and attributes of successful leaders is that they learn to pivot, and they take input and take feedback because they're so focused on achieving a goal and bringing people along with them on that goal. And so you have to listen. And I think one of the things about training, both in medicine and in pharmacy, is it's such a privilege to get to be so close to patients, to really hear their stories and hear their experiences and try as much as possible to embody their experiences, because what you're looking for is opportunities to do things differently. And you're also training yourself to incorporate information, form an opinion, and take action on the basis of that information. That's what healthcare is, really. But we lose sight of that sometimes when we don't listen to our patients. And so I would say number one is learn to be a really good listener and take in what you're hearing, incorporate it, and don't be afraid to come up with a solution or a point of view that's unusual, to challenge the status quo because you've heard something or you've experienced something that seems to indicate that perhaps we need to do things differently. I think that's one piece. The other thing I think you can do as a student is it's such a great opportunity to observe where the system isn't working, and to try to solve some problems. They may be small problems, but try to test things out. Get the practice of saying, "Excuse me, I have an idea. Will you follow me for a minute?" And convince people to follow you, because that's what leadership is, right? And so typically as a student, you're the most junior person on the team. What better experience to learn to convince other people to follow you on a slightly different path? And that, I think, is a really great opportunity. It takes a lot of courage, but it takes practice. And because people will say no to you a lot, I've been said no to a lot. You'll learn that sometimes your delivery needs to change, and maybe you need to be a little less combative or a little bit more strategic. You can learn that stuff through practice, and that, I think, becomes a really important attribute. And then finally, I think, and I know medical and pharmacy education is changing, but certainly when I was going through my training, we didn't get a lot of training in operations. Just how do you make a plan from A to B and solve the problems? How do you make a budget? How do you make a strategic plan and break a goal down into all of its component steps? And so I would really encourage people to seize any opportunity to, particularly in extracurriculars, leadership of a club, a society, a campaign, an activism group, to just set a goal, break it down into all its component parts, explain those parts to people, delegate activities to folks, track, measure, learn, rinse, repeat. And you can do that in all domains of your life.
You talked about, I think from the start, you could get the key of listening to the patient. What tips can you share about doing that when physicians are dealing with, limited time and they have the electronic medical records? I can say as a patient, there are times I feel like the doctor is paying more attention to that dang computer than me sitting over there. It's like, hello, put the computer down. What have you learned along the way that people, with all the constraints that there are, that you can still, really hear and get to know your patients with the limitations that there are?
Yeah, I think one thing is just taking a moment, no matter what, to figure out what way is authentic to you. And for me, it's, in the hospital, I would sit down at the bedside. I like to touch people, put a hand on shoulder, on the arm, and just like eyeball to eyeball, like human to human, like look at a person. And it doesn't take a long time, but it creates that invitation to engage. And so I always, just really think that taking a moment, probably before you even enter the room, to remind yourself to slow down and give it a few seconds. And it doesn't take a long time to just really listen. I think the other thing that's always compelled me is the data around how quickly we interrupt patients typically. And I'm very sensitive to interrupters. I don't like being interrupted. I know it's horrible. So I'm like super sensitive to interrupters. And so try not to be an interrupter, I think, is a good one. I think there are ways to steer people. And very few are the people who will just talk your ear off without stopping. Actually, more often than not, people will stop if you just give them a second, but they'll tell you how they're feeling. And that's so important. And the fact that you sat and listened to the entire explanation means a lot. It helps to foster trust. And I also think that that sort of piece around vulnerability as a healthcare provider is really important. I don't wear a white coat in clinic. I don't perseverate over whether you call me doctor, blah, 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 or just by my first name. I am more comfortable. I've learned ways, and I think this is really important for people to do this, like learned ways to share of myself without feeling overly exposed to my patients, because it's a relationship. And goodness gracious, I expect you to tell me what you ate last night, what your poop looked like, where you slept, and you know nothing about me? Like that feels really intrusive. It doesn't feel very safe. And when we think about, emotional safety within a relationship, I'm not saying we need to reciprocate. The patient doesn't need to know my medical history in order for me to know theirs, but it'd be nice for them to know that like I'm a human and to feel like they know a little bit about me and that I trust them with who I am. And I think that there are ways to do that. First, of stripping ourselves physically of that sort of armor we wear, and then by just being present and joyful and accessible in a way that that starts to invite reciprocity from the patients that we're holding space with.
Yeah. Let's just say, as a patient, I think the best doctors are the ones you realize they've been in a bunch of different rooms, but you don't feel like you feel like you're the only patient they have, when you get in there. Well, I think I really appreciate you answering all these questions and sharing some of your knowledge and experience and a lot of good tips. I think that we all can learn from. Dr. Langell, are you wrapping it up then, or?
I will. Thank you, Cheryl.
Thank you, Cheryl.
Thank you.
Dr. Ajayi, thank you for that absolutely wonderful conversation. This is exactly why we've stood up Vitals, to be able to hear from leaders like you and the great work that you're doing, a compelling, a patient-centered, and an empathetic approach to care. And I think listening to you tonight, the audience, especially, I think all of us, not just our students, can look at this and say that in this time where medicine is focused as a business, where we highlight all the problems that exist, that you've shown us that there is promise and that there is hope, that we can actually deliver care the way we all thought we could when we entered healthcare from very beginning stages. So thank you so much for this tonight.
Thank you so much.
And Cheryl, Thank you so much for the wonderful moderation tonight. We appreciate your expertise in this area. I invite all of you to come back and join us next month as we return to Vitals with our guest speaker, Dr. Cliff Magarian, the new CEO of University Hospitals in Northeast Ohio, for an absolutely wonderful conversation about the things he's doing to improve healthcare through the UH system. Thank you all and have a wonderful night. Stay engaged and remember to lead change, just as Dr. Ajayi has been doing.
Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.